And if you look...
Well, let's get to business. While the Public Health Foundation of India, and indeed the world as a whole, must address all of the public health challenges, including maternal and child health and infectious diseases, it is quite clear that at this point in time, non-communicable diseases have indeed emerged as the #1 threat to public health across the world. And this is going to be the main challenge of the 21st century. Indeed, if you look at the global burden of disease study, in the world, we have seen a rise in the total mortality due to non-communicable diseases between 1990 and 2010. And 80% of the deaths due to NCDs currently are in the low and middle income countries. 90% of the NCD-related deaths which occur below the age of 60 years are in the low and middle income countries. And this is quite evidenced by the fact that India too has had a fairly large rise in NCD-related mortality between 1990 and 2010. Indeed, the rate of rise has been higher in India than in the world overall. And we will continue on this trajectory unless we take firm action. The fact also remains that it's not the fact of excess rising mortality that is a concern, but of premature mortality. If you take the number of deaths that are occurring in the age group of 35 to 64 years due to cardiovascular disease, about 40% of them actually occur below that age. India lost 9.2 million potentially productive years of life due to these premature cardiovascular deaths in 1990. This will rise close to 18 million by 2030. And this is 570% more than the United States in year 2000, and is going to be 900% more than the United States in year 2030. No country which aspires for accelerated economic development can afford such a hemorrhaging of human resources in the productive prime of midlife. And we also recognize that apart from the staggering $237 billion that the World Health Organization has estimated as our collective loss due to 3 principal NCDs in the period between 2005 and 2015, the economic impact globally is going to be devastating. Indeed, the economic burden of NCDs in developing countries is more than that caused by malaria in 1960s or AIDS in 1990s, according to the Institute of Medicine report, of which I was one of the authors. And the NCDs will lead, according to a Harvard and World Economic Forum study, to a $30 trillion loss globally between 2011 and 2030, and if we add mental health to it, the loss will be $47 trillion. Indeed, India too loses about 3 to 4% of its GDP currently because of NCDs. We do now recognize the major risk factors for NCDs, and this again is from the Global Burden of Disease study, where a constellation of dietary factors and physical inactivity constitute the largest contributor, along with tobacco. And blood pressure, as a biological risk factor, rises to the top of the league. And when we look at the big 3 in the Indian context, and look at tobacco, hypertension, and diabetes, we recognize that we, in 2011, had about 61 million persons with diabetes, which is going to rise to about 101 million by 2030. Again, hypertension, clinical hypertension is going to rise from 140 million to 214 million, and tobacco-related deaths, which are only smoking-related deaths according to this estimate, not taking into account oral tobacco or passive smoking, will rise from 1 million plus to about 2 million plus. Therefore, it's not surprising that the United Nations in 2011 set global targets for reduction of premature mortality in the age group of 30 to 70 globally, asking for a 25% reduction by 2030 compared to a baseline of 2011. It is also hinged to action on risk factors which principally drive the epidemic. Therefore, targets have also been set for reduction in the harmful use of alcohol, physical inactivity, salt or sodium intake, tobacco use, raise blood pressure to be reduced by 25%, and diabetes and obesity to be halted, if not reversed. At the same time, it is recognized that health systems will have to be pivotal in their contributions as well. And here, coverage, adequate coverage with life-saving drugs of people at high risk, at least to 50% was set as a modest target, and access to essential medicines and technologies to increase by at least up to 80% globally. Now, if we want a comprehensive response in order to address all of these targets and goals, clearly we need to strengthen our surveillance systems, both for the disease burden as well as for the risk factors, to keep track and to evaluate the success of our policies and programs. We need multi-sectoral action for prevention, both to promote health literacy among the population so that they can protect, preserve, and promote their own health, but at the same time, macro policies which create a conducive environment wherein which people can make and maintain healthy living choices across a life course. At the same time, we need to galvanize our NCD-related health services by creating a competent workforce, by making essential drugs available and technology also accessible. But at this point in time, when we are talking about universal health coverage as an essential right of every citizen, we need to ensure that NCD-related components are also firmly positioned at all levels of healthcare, from primary, secondary, to tertiary care. Now, we do learn from the global knowledge, and we can considerably shorten our transition to effective prevention and control by profiting from the global knowledge base. If you look at the impact model, we recognize that countries which have actually experienced a substantial decline in cardiovascular mortality have done so through a combination of interventions which reduce risk factors both at the population level and at the individual level, as well as through effective treatments. The proportions may vary across populations, but let us say it's about 50-50. So we do need a combination of both. But let us not underestimate the power of policy, even to have short-term impact. Tobacco, for example, there is worldwide evidence that taxation, advertising bans, smoke-free policies, and health warnings have a profound impact in terms of reducing mortality and morbidity. Indeed, 48.1% of the total mortality reduction averted in the United Kingdom between 1981 and 2000 is attributable to reduced smoking. And in terms of diet, we also have evidence from Mauritius where the price subsidies in the public distribution system shifted from palm oil to soybean oil and brought down the population mean cholesterol levels within 5 years. Or Poland or Finland, which is the poster child for prevention in Europe, all of these demonstrate very clearly that policies do have a profound impact. And now we are seeing global initiatives coming in the policy arena in the form of food labeling, reduce salt in processed foods, ban on trans fats ranging from New York City to Denmark, and advertising restrictions of junk foods to children. But to the skeptics who wonder whether policy really has such an impact, here we have evidence from both France and South Africa that increased tobacco taxation in a very short time is paralleled by reduced consumption. The rule is triple, half, double. Tripling of cigarette prices, half the consumption, and double the inflation-adjusted government recognized and provided the required care at all levels of care, but particularly in primary care. So we need to educate people for increasing self-referral, professionals for increasing opportunistic screening, initially using non-laboratory methods, which are fairly effective in triage of the risk, and then subsequently after risk stratification, send for targeted screening, which has laboratory components for diabetes, dyslipidemia, and assessment of NCD. And then follow it up with management guidelines, which combines lifestyle measures and drugs as necessary. But fortunately now, we have several affordable technologies which make this much easier in terms of point-of-care diagnostics, with additional decision support systems, mHealth, and all of these make our task easier. Now, given the fact that in many of the low and middle income countries, we do have a health workforce crisis, not enough doctors available across the country, and not even enough nurses for that matter in several countries, how do we bridge the gap? In KwaZulu-Natal in South Africa, the nurses were able to control 68% of the patients with diabetes, 82% of the patients with hypertension, 84% of the patients with asthma, with a marked increase in treatment adherence. In Iran, trained community health workers could successfully control both blood pressure and diabetes in community settings. And in India and Pakistan, too, World Health Organization risk management package was successfully implemented by community health workers in pilot studies. So we do have some knowledge, even from low and middle income countries, that we can actually utilize effectively for our health system. Are these cost effective? The WHO has declared very clearly that all of these, whether it's interventions related to tobacco or dietary salt or obesity or physical activity, inactivity, or directed at alcohol, or at drug therapy for high-risk individuals with essential cardiovascular drugs, all of these are very cost-effective. And indeed, most cost-effective in India, according to their estimates. So we cannot really say that we do not have cost-effective interventions which we can readily adopt. I would like to say that the health of persons, that is individuals, people, that is communities, and populations, that is countries, or large population segments, requires different levels of action. Indeed, we need to address all of these in our comprehensive response. Policy initiatives to reduce population-level risk include tobacco control, dietary salt reduction, in which industry must also collaborate in terms of reducing the salt in the processed food, and individuals too must be educated, promoting healthy oils, promoting physical activity. Then in terms of communities, settings-based health promotion programs which involve schools and colleges, work sites with home outreach to the families, and community groups such as resident welfare associations. But in terms of reducing individual risk, where the health system or the healthcare system becomes very important, we need early detection and reduction of risk factors before they translate into clinical events, effective referral and follow-up linkages, cost-effective acute care, quality improvement programs to strengthen secondary prevention, innovative methods of delivering healthcare and alternate healthcare models, and context-specific guidelines for disease management. Indeed, the spectrum of NCD prevention and control must extend from policy to pulse. And therefore, what we now need to do is to combine the global learnings of knowledge that has been accumulated in different countries and add Indian innovations in terms of how to deliver, to make it much more contextualized, to develop both health sector programs as well as multi-sectoral interventions, which are certainly to be evidence-based, but also context-specific, resource-sensitive, culturally compatible, and equity-promoting. And thereby, we transform knowledge to action as we proclaim in the PHFI logo. Thank you.